after 1 year of implementation. We will then have a panel discussion, which we anticipate to be an interactive discussion from a diverse representation of RBF implementers in Uganda. We will start off with our first panelist, who is Dr. Sarah Byachika, who is the Commissioner of Health Services, Planning, Financing and Policy from the Ministry of Health, who will give us the key drivers of change in RBF to date. Next, we will pivot to the subnational level or local government level with Dr. Mohamed Mulongo, who is a national RBF facilitator, but also the acting district health officer for Bulambuli district, who will give us a snapshot of the successes as well as the challenges of implementing RBF within the mainstream approach. And lastly, but not least, we will have Professor Freddy Sengoba, who is a professor from the Makerere School of Public Health, take us through what he thinks from his perspective are the current as well as future research priorities of strategic purchasing, focusing in on RBF. We anticipate to take some questions from you guys, so we expect you to be very involved. Please drop your questions in the question and answer dialogue box there. We shall have a team monitoring them, and we will pose 3 questions to the panelists. We will then have our discussant for the day, Ms. Christabella Vewe, who is a National Professional Officer from the WHO, focusing on healthcare financing, to give us insights based on the presentation today, as well as the panel discussion on what are the key priorities for health financing and how this webinar fits into those priorities. We will have Dr. Aloysius come in to give us a wrap-up as well as quick next steps, and we'll finish off with Dr. Sarah Byachika, who will give us parting thoughts as well as close this webinar. That is what we anticipate, but before we start, we have some ground rules. First and foremost, our apologies, we've had to mute all your microphones as well as video so that it doesn't interrupt everyone. This is an all-English webinar, so we anticipate that you'll be able to flow in the language we've chosen, and our apologies if there's anyone who needs translation. Please drop any comments that you have, reflections as well as asks for further information in the chat. And then we shall have all the questions going to the Q&A. For the panelists, we are going to prioritize the Q&A, so please make sure your questions are in the right place. And without further ado, I would like to hand over to Dr. Eric to start us off. Dr. Eric, over to you.
Thank you, Angela, and greetings to everyone who has joined us today. Eric Tabusiwa is my name, and I'll be taking us through our journey as far as implementation of the mainstreaming of results-based financing is concerned, and a highlight on key lessons that we've learned so far. This first slide really is just a snapshot of what Uganda, the financing for the health sector looks like. And as has been the case over the years, government transfers, we receive funds through the government transfers, but primarily the bigger volume comes through the external aid, and the out-of-pocket financing has been the case, as you can see, over the years. And specifically, the primary healthcare services are primarily financed through the conditional grants for salaries, wages, medicines, and facility operations, as well as funds for development, for facility upgrades and the like. And over time, we've seen that PHC grants have grown substantively, and currently, through the Uganda Intergovernmental Fiscal Transfer Reform, results-based financing was mainstreamed into the financing for PHC. And this is a journey we are still on. It's still the first year of implementation. But on the right side, it's clear, just to highlight that the bulk of the funds end up at the local governments. even what looks like donor money is voted centrally at the Ministry of Health, but it's finally sent to the local governments primarily through the vertical programs and some of the other programs like Global Fund and the like. So the financing really, this is just a summary of what it looks like. And next slide. So under the AMCHIP, Uganda has over 20 years experience with results-based financing, and a 5-year intervention that was rolled out nationally was recently concluded, and it primarily focused on incentivizing services that were in the reproductive, maternal, child, and reproductive health services. It was rolled out in a phased manner and primarily looked at incentivizing outputs and quality at both lower level facilities, hospitals, selected hospitals, and the local government offices. On the right is really what the package looked like, and just specifically differing from the current that we are currently doing. Each indicator had a fee that was tagged to it. And there were system level interventions, monitoring, oversight, etc. And incentives were both to the local government and the health facilities that were implementing. And we saw an improvement in the utilization of services. In addition to the vital statistics, documentation for this was improved at the facilities. And also to a certain extent during the early phase of the COVID pandemic, it was clear that facilities were able to purchase and procure PPEs prior to the other resources coming on board. This is really a slide just to highlight that there was a substantial increase in the resources that were available for recurrent expenditure at facility level, and a big chunk, up to almost 70% of the resources that were available for utilization were really through the results-based financing mechanism. And this was steady across time. And we also saw an increase in the quality, the scores, an increase in the quality of the services as evidenced by the increased threshold for the scores, as you can see on the graph to the right, which was one of the core objectives of the intervention under the AMCHIP. This is a summary from a study that was undertaken with support from the World Bank and ThinkWell. A difference in different study was undertaken really to tease out the actual impact of results-based financing across the indicators that were being incentivized. And what we saw, there was statistically significant impact in the increased utilization of a number of services ranging from 0.01%, but it was a statistically significant increase in the utilization of services over time from the survey, from the study that was conducted. Next slide. So how have we gotten here? So under the mainstream, some of the core, those need to sustain the gains that were seen, and given the fact that the AMCHIP was a project that was coming to an end, and there was an effort to really, by the government of Uganda, with financing through MOFPED, Ministry of Finance, to institutionalize results-based financing to the sector conditional grants. A strategy on how this was to be done was developed in a consultative manner, which took about 1 to 2 years. And the key RBF principles, an effort was made to ensure that these principles are incorporated into the strategy as much as possible, and specifically into the financing for PHC, for level 3 and for facilities. And some of the partners, key partners included Ministry of Finance, the World Bank, and a technical advisory group was constituted to really run with it under the leadership of the Commissioner Planning and the Ministry of Health. The current package has a number of layers, but specifically the indicators were selected based on their availability, the availability of data to be able to routinely manage and monitor it, putting into consideration the baseline performance relative to what the policy goals are, what the current sector priorities were at the time, and also the implementation experience that had following the implementation under ANSHIP and the earlier intervention. And there was a clear balance and focus to ensure it's both preventive and curative interventions were considered. And at the onset, 50% of the RBF sub-grant was allocated to the local governments, 70% to the outputs for the eligible health facilities, level 3s and 4s, and 25% was to purchase the quality based on the health facility quality of care assessment program that is an institutionalized assessment for quality in the country. As the strategy was being developed, it's clear that there was a need to balance what the results-based financing principles and priorities are vis-a-vis the public finance management system. And just as an example, under the project mode, there was timely reward for performance. So soon after the end of a quarter, verification will be undertaken, and the results from the outputs and the quality would then be purchased there. And then vis-a-vis in the current setting, we have to have a predictability of resources that will be consumed over the 1-year period, because this is a requirement from the PFM system. So we had to really balance and come up with what is the most appropriate timing of verification and what period of output should be considered. There was a higher level of facility autonomy that was exercised under the project mode, and this was provided for through the design of the program, vis-a-vis in the mainstream, the thresholds to which facilities can procure or certain decisions have already been, the precedence has already been set. So that had to be adequately balanced and to align with the current practice. And then we used to undertake verification on a quarterly basis, which enhanced routine measurements of performance. Vis-a-vis in the current setting, we are only able to do it as meaningfully as possible, twice a year for the verification, once a year for the quality of care assessment, and then we build it into the routine support supervision processes. So this, there's been clearly a balancing act that had to be undertaken, that notwithstanding. Next slide, please. So this is really to highlight the fact, the part that what is in blue, purple, and above the dark line, the dark arrow, is really what the public finance management, the public finance processes and the timelines look like. And the effort really, if I can ask you to pay attention to what is below, the effort was really to make sure that the prerequisite steps that were relevant and to ensure the mainstreaming, as articulated in the strategy, are aligned in timing to the key processes that are undertaken in the PFM cycle. Just as an example, what you see highlighted in yellow are semi-annual verifications, and before the yellow is the HF QAP assessment, which needed to be undertaken in a manner that the assessment results are available, as well as the LGPA results, which are available done between October and December, so that by the time the second budget call circular is being undertaken, we've been able to come up with the planning figures, the estimates for the funds that the facilities will be receiving and the local government subsequent financial year. So the effort was really to align with the PFM processes, given that Ministry of Finance is a key stakeholder. We are talking financing, so the allocation had to be in line with the system. Next slide. Multiple stakeholders were engaged from the onset, and in the design, we had to bring on board the views of course, Ministry of Health leadership, technical departments, as well as Ministry of Finance, and the other stakeholders, ThinkWell, Enable, and ODI, as part of brainstorming, so that we can see how best we can design a strategy that is responsive to the requirements. Further engagement was undertaken through the orientation of local governments, where partners also involved. And we've been implementing for the last 1 year. And it's clear that the roles of the different stakeholders, Ministry of Finance, Ministry of Local Government, Office of the Auditor General, and Office of the Prime Minister, all have a stake in as far as a mainstreamed approach is concerned, because we're working within the government structures available. Next slide. So some of the key lessons that we have learned is that, one, you can't underscore the role of the different stakeholders, the key players. And it's important to note that, yes, Ministry of Finance is key, and it's important to align whatever strategy or plan within the medium-term plans for the different interventions, especially from a financing perspective. Health financing has a reform whose impact reaches far beyond the health sector and beyond health as an MDA. Other MDAs have a key role to play. And it is important that the expectations of the different stakeholders are actually put in consideration. For example, under the project mode, we had a staff incentive, and which was not provided for in the public service structures, in the public service way of doing things. So this had to be carefully considered, because pushing for it would mean you may need to, it would be a very long dialogue, and you need the Ministry of Public Service and other stakeholders to come on board. It has cost implications. We've been able to roll out to the entire country. We have a total of 176 local governments. This was done in the earlier part of this current financial year, and funds have been transferred to the health facilities and local government health offices in a seamlessly timely manner, in line with the current practice. And we've been able to undertake all the key relevant processes to date for the first 1 year, thanks to the coordination of our bosses. And also, as a key highlight, all local governments plus their health facilities have been supported to develop integrated work plans, which is a key plus if you're looking at efficiencies in resource use and planning. Of course, the plan is to monitor the execution of these plans in the subsequent financial year. Next slide, please. Yes. One of the key issues at facility level and from our experience in support supervision is that, much as they're clearly the releases to the local governments there's a clear release and communication that X is for the input and Y is for as a result of your performance from the preceding calendar year. The funds, when warranted, are paid in a lump sum. So at facility level, sometimes, much as there's prior communication, there's no clear teasing apart which is due to which fund, which proportion is due to their performance in the preceding period. There are different, so there are issues regarding to local governments are constituted by both districts, municipalities, and cities. But some of the challenge we've seen is that the cities and municipalities at different levels of capacity to implement and oversight in comparison to the local governments. And in some cases, you find one or two municipalities don't even have a facility that is at the level of care that is benefiting from the intervention. There's been some issues pertaining to the quality of data, and this is part of what we've been working through in the last 1 year to improve in support as the Ministry of Health. And for the last few assessments, as we do support supervision routinely, we are seeing an improvement in this. The different processes are also an opportunity to keep touching base with the status of data accuracy. Future opportunities, potential. There could be value in exploring considerations for enhanced facility autonomy. As an example, we've had a threshold for micro procurements at the equivalent of $250 to $300 for the health facility. Is there room for this to be explored further once capacity has been built to manage the resources and to plan adequately, now that we are doing integrated work plans? Yes, there is need and we see value in reorientation of local governments with a focus on the municipalities and cities, especially given their challenges with human resource capacity. And we are currently undertaking verification at semi-annually, so twice a year. Can there be an opportunity for institutionalization of, be it verifications or quality assessments that are under the leadership of the district local governments, so that as we move forward, the drive to improve the quality is clearly being quality and accuracy of data is really being driven strongly by the responsible authorities. I would like to acknowledge the Ministry of Health, Senior Management, Planning Department, Ministry of Finance for the support and critique through the years. Makerere School of Public Health that has been a key partner in the design and continuous monitoring. Different local governments are for routinely being available for cooperation. The World Bank, WHO, Enabel, and ThinkWell that has played a key role in the documentation from design up to now. Ladies and gentlemen, thank you.
Wow, thank you so much, Dr. Eric. That was a roller coaster. I hope some of us are not suffering from information overload, but we really, really appreciate you taking us on that journey all the way from RBF under the project mode, what you consider to do the mainstreaming, as well as the key changes. We shall now get into our panel. And our first panelist is Dr. Sarah Biachika, who is a Commissioner Health Services, Planning, Financing, and Policy in the Ministry of Health. And Dr. Sarah, Dr. Eric has alluded to the changes, a number of changes, or the drivers of the number of changes from AMCHIP as we got into the mainstreamed approach of implementing RBF into government systems. Could you please now take us through some of the significant differences between the project mode as well as the current mainstream approach? What were the main factors that drove these changes, but also the processes through which these key decisions were reached and how consensus was built? Over to you, Dr. Sarah.
Thank you very much, Angela. Good afternoon or good morning to all of you based on where your location is. And I will straight away delve into the intricacies of the results-based financing system and try to help us to understand how we evolved from the project mode and mainstreamed or institutionalized this approach into our primary healthcare financing. I'll be highlighting some differences. I'll focus on 4 key differences around the benefits package, the periodic assessments that were conducted, health workers' incentives, and the autonomy in the utilization of the RBF incentives or payments that facilities were receiving. So in terms of the change in the benefits package, we see that the project, which was the Uganda Reproductive, Maternal and Child Health Improvement Project, was tailored to reproductive and maternal and child health. So obviously the package or incentivized package that we agreed on or that was developed was selected from the Maternal and Child Health Services Program list of indicators. As we transitioned from the project and streamlined RBF into our primary healthcare financing, it became evident that the benefits package had also to be broadened or to change in line with the priorities of the sector. So now we have a broader range of indicators to include some of the priority programs, HIV, TB, malaria, and non-communicable diseases. Just to share with you, this transition or selection of indicators was not an easy task. It was uphill. We already know that most of the programs had already we had shared and they had learned about the benefits of results-based financing in terms of performance. So almost every program wanted to now enroll or benefit from the RBF program as it was being institutionalized. So we had an uphill task, but through our RBF task force and other structures of Ministry of Health, were able to engage the different programs to come up and different departments in the ministry to come up with the starting package for RBF institutionalization. So as I mentioned earlier, we have to come up with a criteria which was largely informed by our health priorities as a country, ensuring that we address both health promotion, disease prevention, as well as the curative services, and also taking into consideration our disease burden, the level of performance in terms of the indicators, because we know if your RBF is an approach that is supposed to lead to improved utilization of services as well as quality and equity. But for you to improve utilization, it means you have gaps. So when you are selecting indicators, you select indicators where there is low performance or low coverage for a specific service. It's not just an issue of incentivizing, because if you have where you have a high coverage, then it loses the whole essence of the impact of RBF on service delivery. In addition, we had to emphasize the importance of including indicators that can be readily obtained from our routine health management information system without having to create parallel systems. So that one is actually cost saving, but also helps you to improve your health information system. And since the system is web-based, is digitized or using the DHIS2, we are also able to routinely monitor on the database up to facility level on the performance and also evaluate without necessarily having to wait for the end of the year. So after extensive deliberations, we developed an indicator selection matrix and narrowed down the list from 22 indicators that had been proposed to 11 indicators that we are now using. Under the project AMCHIP, we actually also had about 11 or 12 indicators for the higher level facilities. So we really said that for ease of monitoring, for ease of incentivizing, it is not good to have a wide range, because even you end up with little financial incentive attached to each indicator. So we had to take care of all those RBF principles and ensure that if you are to incentivize an indicator, there should be reasonable cost attached to that. So we scaled down until we had 11 indicators that we are now incentivizing. I wouldn't want to say that even the current experience after 1 year, we are looking at revising some of those indicators soon due to a number of reasons that may not be for discussion today, but some of them is because if the patients or the people utilizing a specific program area are not many, you may end up with challenges in terms of penalties, in terms of, and all those attached if the numbers are not significant. So you have to select indicators which have quite a high service utilization rate. Second, I talked about another area that is the periodic assessment. And in the project mode, we had a rigorous assessment and verification process for both our quality and quantity indicators before we could pay for them every quarter. So every facility that was participating and local government had to conduct quarterly assessments, which were then validated by the local government health management teams and further counter-verified by the RBF unit. So the central level had to go on a quarterly basis to select facilities in local governments to do counter verification. And based on that, then final invoices would be made for payment. So this verification process, as you all know in RBF, is integral into ensuring and maintaining transparency, accountability, as well as ensuring continuous quality improvement. In the transition mode, we aligned with existing structures after extensive discussion, because we didn't have money for teams to go every quarter to local governments and for health facilities to undertake these rigorous processes. So we had a thorough review of the processes, the tools and systems, and I'm sure Eric, you heard from his presentation, he alluded to this. Instead of having an RBF assessment tool or process, we adapted what our standards department in Ministry of Health, a program called Health Facility Quality of Care Assessment, which was being implemented. And at that time, it was more or less parallel because we had developed our own tools, an abridged version of the HF QAP, and used it as the RBF assessment tool. So we agreed that we build on kind of try to strengthen and further institutionalize the assessment mechanism within the Ministry of Health and have the annual assessments conducted and the quality incentives for the RBF program are then derived from that than having a parallel strategy system for assessing. And also in terms of the district health teams, because we also used to undertake separate verification of the district health teams in terms of their management and support to health facilities to the local governments, we agreed to utilize the local government performance assessment, which is also an incentive-based assessment by the Office of the Prime Minister, so that we can assess the district or local government health teams to be able to provide their crucial oversight function, including supervision and other management roles. And also the district health teams now are incentivized based on the local government performance assessment and not a parallel RBF assessment. So as I see here in assessment, we had to integrate within the existing programs, that is frameworks, that is the health facility quality of care assessment for the quality component, and the local government performance assessment, which is an oversight function through the Office of the Prime Minister. That means we didn't have to have additional resources provided, but separately for these functions. The third area is regarding the health worker incentives. And it was imperative to address the critical component of health worker incentives. Because under the project, 40% of the funding that we had that earned by each health facility or local government would go towards health worker incentives. And this alone enabled the health workers and everybody to really appreciate and see themselves participate in the RBF program, because for the sharing of the 40% incentive was also based on each health worker input into the program as perceived by the health facility. But when we came to mainstreaming, it became a very, very touchy issue. And I would like to say that it should have been really a negative impact on health service delivery. But around the same time, we as a government, we had an enhancement in the health workers' salary. So the whole of government of Uganda through Ministry of Finance was asking us, Ministry of Health, you are mainstreaming RBF into primary health care financing using government of Uganda financing. It is no longer project mode. The same government has just enhanced the health workers' salary compared to all other workers in the government. Now, how will it look? Again, the same government of Uganda is using that very money, government of Uganda funding, to again top up or to motivate or provide additional incentive to health workers to provide services that they are paid salary for. So the top management of Ministry of Health immediately concurred with Ministry of Finance that based on our fiscal space, it is better that the financial incentive for health workers under government of Uganda would not really be appropriate. Secondly, it is not in line with our public service standing orders. So a decision was taken to exclude the financial incentive from the RBF payments as was in the AMCHIP project. And this was a significant thing. And some proponents of RBF still think that no, there must be some kind of financial incentives for health workers. But really for our case, it was a bit of a tricky government. But we allow that as the financing still available at facilities, and the managers and the facilities can still plan to ensure that incentives can go to health workers in terms of improving the work environment, in terms of other non-financial incentives, using that money, but not directly paying workers at the end of the quarter as a financial incentive. Lastly, I would like to talk about the facility autonomy, which you all know when you talk about the RBF principles is very, very critical. And in our AMCHIP, or in the project mode for RBF, this was very pivotal in that it allowed health facilities to address their unique challenges and priorities. Facilities had to come up with performance improvement plans and plan where can we invest this money. And for sure, it was a game changer. And also, we know that in order to address issues of service or uptake of utilization, availability of medicines is very critical. And this money under RBF was very, very important, because we see that up to about 10% of that funding was used for procuring of additional essential medicines and health supplies to enable the facilities achieve their indicators. And they could procure these medicines through joint medical stores, which was also to some level a way of control and not allow them to procure from any other facility, just to ensure quality, but also to be able to track where this money was going. So as we transitioned from RBF, and as per the government of Uganda principle, all drugs or medicines and health supplies are supplied through our national medical stores. And therefore, this area of autonomy, we could not maintain it in the area of procurement of additional medicines using the RBF grant. Medicines have to be procured from national medical stores. So this is a bit of a restrictive area, and it's also a presidential directive which we cannot go against. Medicines to public facilities have to be distributed through the national medical stores. However, I would like to say that we also, as Ministry of Health, appreciated that there is stock out of some of these essential medicines. We cannot hide our heads in the sand. So the additional funding that we received in year 2 for RBF, that is in the coming financial year, as we mainstreamed RBF, the government also has increased funding, and we really earmarked that additional funding specifically to enhance availability of medicines and health supplies, because the financial side in terms of RBF is catered for to some extent through the grants, the PHC grant, but the financing for medicines was a gap. So with this enhancement, we expect that it will still help us to sustain our gains as far as RBF, the impact of RBF on health service delivery is concerned. So in conclusion, these changes were not made lightly. They were a result of deliberation, a result of give and take, but more so having a shared vision for a more efficient, effective, and integrated RBF system. As we continue on this journey, we remain steadfast and in our commitment to improving the health outcomes of our population. Thank you very much, Angela. Back to you.
Thank you very much, Dr. Sarah. It's always a pleasure to bask in the wealth of knowledge that you have. You have talked about the intricacies of change. Most of these happen to be at the local government or subnational level. And we are privileged to have Dr. Mlongo, who is the District Health Officer of Lambuli, to join us today. So Dr. Mlongo, pivoting to you, reflecting on the first year of the mainstreamed approach from this perspective of the districts, what are the notable successes? especially in terms of health service utilization that you're noticing in your area of work or in your district, but also what could be some of the most pressing challenges as we moved to this mainstreamed approach.
Thank you so much, Angela, for that question. Thank you very much, Dr. Biachik and Dr. Eric, for the initial presentation. Yes, we are in the first year of implementation of the RBF. And so far as the beneficiaries of the program, that's the local governments, the health facilities, we are in the transition period, moving away from the project mode to now the mainstreamed approach where we have RBF combined with PHC coming together. Initially, this was not well understood because people were not able to appreciate that RBF was coming together with PHC, and even some facilities are only good to know when the funds were in their accounts. It started with us developing integrated work plans. Like Dr. Biachik has said, initially we had RBF having the performance improvement plan, which was separate from the PHC work plan. So when we develop these plans to get into merge them into one, that is HMI-01, we have resolved the issue of duplication between RBF and PHC. It has helped us with that. And it has helped us to transition from the mode where we thought RBF was only for maternal and child health interventions, like Dr. Biachik has said. But what has helped us also is that the RBF incentives had also become a challenge in that in some facilities where perhaps was not well shared, it was not shared well, it could cause some bit of conflicts. But now that it was removed and staff payments and salaries were enhanced, we see now a deliberate effort by government to stabilize that situation. We have also basically removed the system, some of the system challenges we had, like Dr. Eric said, the invoicing process. Every quarter, your facilities have to develop the invoice. It goes to the district, from the district to the region officer, to the ministry, and then the labor-intensive process of verification by the districts. Really, that has really been removed, and want to thank the ministry for streamlining that kind of process. And what is also, however, what is maintained, like Dr. Biachik said, is RBF continues to drive performance management, that facilities see that if they don't perform, they have something to lose. And the district officials put pressure on facilities to ensure that they perform in order to improve their income. But that said, there are still some challenges, like everything that is new comes, we're still learning. Like Dr. Biachik said, people feel that we have lost some of the good aspects that we had with the RBF mainstreaming, RBF projects. In the mainstream approach, we have lost the aspect of infrastructure improvements, which were agreed, which were permissible under the project mode. People had to do improvements of renovations to make the maternities habitable, the waiting sheds, all that, procuring equipment, buying some additional medicines. So, but with the current fiscal policy, PHC funds are not allowed to do infrastructure improvements, equipment, and medicines. So, although there is another kind of strategy to ensure that this is provided, we know that people feel they have lost that opportunity. But also, something that needs to be clear is, should we condition RBF within the mainstreaming approach? Say, for example, even if PHC is coming together with RBF, at the time of planning, should we be able to say there are these issues like, say, community engagement or certain factors that improve indicators? Should we try to condition some of these funds, or we should let go? Suppose it's in a situation where a facility plans for funds and most of it is going toward administrative expenditures, or what we do in such a situation. So those are some of the issues which are coming up, but also sustainability of monitoring of the quality of care. Dr. Miachika has ably put it that we are now using the quality of care, the health facility quality of assessment that is used to assess at an annual basis. However, under the project mode, we used to conduct quarterly quality assessments. So moving to an annual assessment for quality seems to be good, but it also reduces the effort, the pressure we had put on facilities to be able to take note of their quality assessments. So, but by and large, this is work in progress as districts and as health facilities. I think mainstreaming is taking a place well, and we think that by the end of, within the second year, some of the challenges we're facing now will have been resolved. Thank you so much.
Sure. Thank you so much, Dr. Mlongo, and thank you for giving us back 1 minute. That was impressive. I can hear you speak to mixed evidence coming in. Of course, we saw incentives being a big part of RBF under UNCHIP, but also thought that the invoicing process as well as the routine verification was really good. As we draw to Professor Freddie, we need to understand, looking at the context of Uganda and where we are today, the landscape, what he thinks are specific areas that require deeper investigation to enhance the effectiveness and sustainability of RBF going forward. So, Prof, over to you. We are having mixed evidence. What do you think our research priorities should be going forward?
Thank you, Chair, and good afternoon, good morning, wherever you are. It's an interesting discussion. I want to thank the speakers who have laid a very interesting foundation for us to discuss. This is a topic that, of course, I love, and it's been probably part of my career development. So it's always great to come and reflect on the changes, innovations of this animal over the years. As the presentation went, especially from Dr. Erica and from Dr. Sarah, I could think of 3 or 4 stories, lines that have emerged for me to reflect on, especially on how to think of the key issues of RBF sinking into, or at least settling into the health system, but also issues that we need to pay attention to. One is about reflecting on progress over time, and clearly, since the early days of 2003, when the first RBF program was launched in this country, I think a lot has been done. There was a early phase of indifference where actions were taking place in the rural setting with local governments and very little leadership at the center. And we see that has changed. We were able to see a multi-year program that at least has rolled out across the country through 3 phases with active leadership and stewardship of the ministry. I think we need to celebrate that. I believe there is a capacity that now has also come to the national level. Previously, we had seen a lot happening at the local government where these projects were camping. But as Dr. Eric also reflected, that capacity that we were seeing at local government may not be reaching the cities. And so the question might be, how do we get these other entities that in many cases tend to handle more complex health issues, especially around urban areas, to also gain competence. And I think as we think of the next phase of learning is trying to pick up on those areas that were not initially captured. I think the question that Eric also reflected on, which relates to this matter, is about some agencies or some facilities or some districts being left behind, and how we deal with RBF challenge of the fact that it usually goes with the strong ones, or at least accreditation that picks those that are capable, and may leave behind those that are weak, is something that we really need now to rebalance. I'm happy to note, though, in Dr. Sarah's remarks that the redesign seems now to be picking up, or at least focusing on the weak and trying to build them up. In other words, going into development as opposed to trying to leverage the capacity that is already in the system. I think being the country called Uganda we are talking about is more development to do than leveraging the strong ones. So I think there are strong lessons there, and I believe we are starting to solve one of them, especially as we look at progress. I also was impressed to see that despite the three-phased approach, even those districts that came later were able to see some improvement, although, of course, those that entered the program much earlier seemed to make a lot more progress, which also speaks to these interventions when they come and they are based on public policy, they are based on national funds and loans. The communities we leave behind can potentially be a political issue. I did not hear very much about politics other than thinking about public finance management system. But that is another area we really need to pay attention to, the politics of RBF and how it might be now, I think, time to point us in a sense that the project had more space, decision space to allow incentives to work. But now those incentives are being diluted, to some degree removed. And that speaks to the new challenge. Are we going forward? Are we going to be talking of RBF, or we are talking of another kind of project that has replaced it? In other words, is the animal still the same animal as we move forward? From Sarah's remarks, I wasn't sure whether in the next phase of the mainstream RBF, whether the principles that were holding this concept across the globe and the design, whether they are holding true. I seemed to hear that they're actually being eroded. So the question then would be for us to think of what is the minimum specifications that we can have if we are going to call it RBF, or can we invent another kind of concept that allows us to rebaptize this as it settles into the program. This I'm saying not in terms of cynical ways, but I'm thinking that many programs continue to keep original branding when in actual sense they've changed. And as academic people, we usually want to call things what they are. If it crackles like a duck, walks like a duck, then it should be a duck. But somehow in bureaucracy and sometimes in development, nice terms are kept even when the operating logic has totally changed. So that is the first reflection I had. And I think research here is to think about how are we eventually operationalizing these concepts around accountability, around incentivization, around performance audit, and purchasing. If we are talking of strategic purchasing, how is this actually being commissioned? Is contracting any more worth doing? Remember, if you enter a contract, these elements are going to be critical. Otherwise, it goes back to input-based financing where there is no incentive, there is no really motivation to drive performance. Second part is about public financing system and the rigidities that are being reintroduced. I know when we started off with RBF trying to design even the model for Uganda, we were trying to see how do we get a model that is closer to the institutional arrangements in the country in terms of local government, national level, in terms of performance mandates, in terms of resources and how resources are distributed, purchasing, autonomy, and decision space. And of course, one of the interesting aspects that Uganda should probably be selling out to the world is about how we tried to redesign the verification processes around RBF, make them sync within the mandates of the institution. If it's local government, if it's the ministry, if it is public finance systems. And I think these areas of trying to customize, usually, as Sarah said, it's a negotiation. Sometimes the big boys will beat you at it and you have to go along with them. But I think for me, it is not a negotiation that is done in one sitting. As a community of public health practitioners, financing experts, we really need to keep trying to renegotiate this space and hopefully see how some of the principles that are essential for accountability and performance to be maintained, to come back if we didn't negotiate it in the first instance, how can we over time try to negotiate them back? So Sarah, I think for me, the question is how over time can we renegotiate? And this can be even a research process. We do political economy studies to understand where the entry points. I know that schooling and school systems are also jumping on board and they are having a clear metric which we may not have. But in there may be room for us to renegotiate it with the education and other players that are coming on board. I see electrification is also coming on this. So there are more partners what we need to bring into the same room to think about this. As I finish, I think we also need to reflect on the finance and finance adequacy. Broadly, I think what we are seeing is not so much that the public finance management system is introducing rigidity. I think the big one is that there isn't enough money to sustain a model that should ideally be based on incentives that should drive the providers to actually do more, or at least to be able to take decisions that are efficient, or to try to pick up those goals that should be the expectation of the national plan. But if you can see, when we had the RMNAC as the program, now we have almost 4 or 5 programs. One cannot stop but think of the dilution of when the money is getting less, it is even being diluted across many programs. What does that mean if you are the provider of a health center for a hospital when you are faced with these kind of decisions? So in economics, there is what we call utility of the contract. If there isn't enough benefit for the efforts one is putting on, then clearly we've walked back into input-based financing. And maybe we just need to accept that that is the direction we seem to be headed, unless we kind of look at this issue of financing adequacy, but also the issue of how we offer decision space for facilities managers to manage without the managerial agency for them to take action on what they see as the bottlenecks for their performance. Then you have to wait for NMS when they choose to bring, and if they bring, what they bring is what you have. At the end of the day, you are not really doing a program that should be building efficiency. You're actually responding to the constraints in the system. And I think financial adequacy and how we have also tied the manager's hand is a key issue. And research, I think, should be addressing this. But overall, I think we have lessons we can talk about. But there is a professor who told to me in London School, he used to say that these reforms, which we used to call managed health, basically the whole managerialism that came into where RBF also sits, he used to say that it's not a game for poor countries. He indicated that it is even for countries like UK under the Thatcher regime, Prime Minister Margaret Thatcher, they had these problems, and many times they walked back into some of the areas like we are doing. So maybe it is a journey that we are traveling. We can try to see how best to get to the destination of interest. Thank you. I'll stop here and hand over to you.
Thank you so much, Prof. You've asked us more questions than we can answer. We have so many questions that are coming in from the chat as well. We are trying our best to prioritize. We have questions on community health systems, as well as how community can, those systems can be built through RBF. We have a number of questions on autonomy and medicines procurement. And we have questions on RBF incentives, as well as communication to local government. I am going to prioritize only 2 questions. Prof, you've given us more questions. So we are not giving you any more question, maybe until we figure out on how to answer your questions. But I would want to take a question from the audience for Dr. Sarah, and I will read it verbatim. Dr. Sarah mentioned that there will be more funds for supplies and medicines due to the mainstreamed RBF not giving autonomy to facilities to procure their own supplies from joint medical stores. How will these additional funds be earmarked for helping facilities have the supplies they need? Will it be in form of more facility or more local government budget for supplies? Or will the money be given to the national medical stores to make sure they have the supplies they need? So Dr. Sarah Sam, please elucidate on medicines in less than a minute.
Thank you very much. And I think I emphasized that procurement of medicines is centralized. So the additional funding for next financial year that is going towards medicine will be procured through national medical stores. We have already provided the list of some of the medicines that we, from our assessment, found that was largely lacking, or where most of the procurements using RBF funds were going, and we have provided to NMS to enhance the package, the essential medicines kits with those supplies. Thank you.
Thank you so much, Dr. Sarah. I am going to take a quick question for you, Dr. Mnongo. I'm going to flip it a little bit. So one of the participants is saying or asking that RBF incentives rely on clear communication and good understanding. How did the Ministry of Health communicate RBF mainstreaming plans to facility staff? Can the facilities see their scores and see how their payments are calculated? Dr. Mnongo, I'm going to nuance this a little bit to ask you as a district health officer, how did you communicate RBF mainstreaming plans to the facilities in your jurisdiction? But also, can these facilities see their scores as well as how the payments were calculated? In less than a minute. Thank you.
Thank you so much, Angela, and the colleague was asked the question. The communication from the minister was very clear through the broad guidelines, orientation meeting. Conducted the assessments, we conduct it with them. When we do verifications of the data, we do it with them. So before a team leaves a facility, they will have seen the scores and the amount of money that is related to the scores. So the transparency is right clear from the facility up to the Ministry of Health. Thank you.
Sure. Thank you so much, Dr. Mnongo. We are overwhelmed by your questions. We are going to type them into a compendium document, attach responses, and share them as we share the materials for this workshop. Sorry, for this webinar. Quickly pivoting, we have a discussant, Ms. Christabel Abewe, who is the National Profession Officer from the WHO. Her core gist of work is healthcare financing. Christabel, you've listened in all the way from the presentation, the very engaging panel. We are overwhelmed with information, and we hope you can synthesize that with us as you share your insights. Over to you, Christabel.
Hey, thank you so much, Angela, and I hope I can be heard well. Greetings to you all. I'm happy to join you today as a discussant for this timely and very interesting webinar. I think before we buttress on the key things that came out, I think it's just really important to highlight the role that strategic purchasing plays in health financing, because it's such a critical lever for us for universal health coverage, as it has a direct bearing on efficiency and also on quality of services offered. So it has a bearing on an intermediate goal of UHC, which is efficiency, but also on a final goal of UHC, which is quality of services offered. So for us, it takes a very, very critical role in the health financing continuum. And when we think about strategic purchasing, there's no one magic bullet, all the provider payment mechanisms are imperfect in one way or another, capitation, results-based financing, fee for service, etc. And what we're seeing now on the global trend is that countries are moving toward blended or mixed strategic purchasing models or methods. For instance, you find some countries combining capitation with some priority services paid fee for service, or even in the case for Uganda, as we now see, we're moving toward using provider performance information, which is RBF, in combination with the usual line item budgets. So to be fair, results-based financing has a very great intuitive appeal to it, because it links financial incentive with actions aimed at improving health or health services or outcomes. And so on paper and in theory, RBF is a very sensible intervention. So for some people on the webinar who might be wondering, is it sensible? Is it not sensible? It is very sensible. And from the presentations and the stellar lineup of panelists that we just had from, we've learned that from Uganda, we've seen or registered several pros associated with this specific reform. And of course, it's still a little late, or a little early rather, it's a little early for us to have a full assessment or understanding of the impact that the mainstream results-based financing will have on the health sector in Uganda. But to quickly summarize what came out of the discussions, it's becoming clear that one, the mainstreamed approach is sustainable in nature. That's what we want. We've moved away from the project mode. We are now mainstreamed in a government structure. From the presenters, we've had that they followed good process. I think good process has been upheld. I think what really stands out is that we've adhered to the institutional governance structures, which has kept the RBF in the confines of the PFM system in Uganda. And that's really important because then everything is on book, everything is on the system. We can see it on the IFMIS. And as you heard from Dr. Sarah and also from Dr. Mlondo, the information is available in DHIS2. So information systems are already picking up the 11 RBF indicators. We've had a nationwide scale up, so we've not introduced any inequities while rolling out this reform. There's been very good process. You've heard about task forces being constituted. I think it was also Dr. Mlondo who mentioned that we removed duplication between results-based financing money and PHC money. I think that's a big win because we're now really looking at how can we efficiently utilize the available resources. So those removing of duplication is really, really critical. And that's why strategic purchasing is such an important lever when we're looking at how can we efficiently operate within the available resources. So overall, there's been good telltale signs. We watch anxiously to see the data that's going to come out and see the broader impact it's had on the health indicators that we're tracking. But we expect that this is going to be a growing journey. We expect that RBF will keep improving as our institutional capacity and our technical capacity in the health sector evolves. We don't expect that it stands still. And so just in terms of going forward, what things we need to buttress on coming out from this discussion. One is that for the mainstreamed RBF to operate optimally or for it to operate at the highest possible frontier, we need to create the right implementation arrangements and supporting systems. And for the RBF to be effective, a set of key functions and capacities to carry those functions out have to be developed. And first on that list is the information system. I don't think we can stress this enough. We've had good stories about the indicators already available in DHIS2. We just need to make sure that this information is actually going to be pulled out, it's going to be utilized to inform decision-making, to inform the verifications and the audits that need to happen. The IT systems are going to be very essential in operating contracts, in generating intelligence on revenues, on expenditures, and also to track provider performance and health system results. So again, I'd like to touch on what Professor Sengova spoke about. Has this thing metamorphosed and taken a new shape? Is it still results-based financing? We need to always reel ourselves back in and ensure that we're upholding those tenets that make RBF what it is. It has to be aligned or anchored in providers' performance and incentives. So we can't really take those aspects out completely. And I'm glad that this is happening in a phased way. So we hope that in the next phases, we are going to see some of the issues on incentives coming back up again, issues on autonomy. I think we really need to go back to critically thinking about how do we enhance provider autonomy and of course, to go with the autonomy's accountability structures. So can we consider to, again, allow health facilities to make, improvements through the facility improvement plans? Facilities really need to be able to respond in an agile and quick way to, whatever needs arise. And so things like the micro procurements that were happening with thresholds in the previous project mode, I think some of those things and aspects need to really be thought about and brought back in. The robust verification and quality assessment and monitoring, again, you've heard that we've moved away from the quarterly verification to the annual. I think any results-based financing model is only as good as how well it's verified. So again, this is something we need to critically think about in the future of mainstreamed RBF for Uganda. We also need appropriate and clear institutional structures. I think you've heard from our local government counterpart that the money came and it was not clear who's supposed to access it, how will it be utilized, how will it be reported on. So those institutional structures need to be well communicated from the center downward to the street level bureaucrat. I think on incentives, we really need to speak more on this. And I understand the political economy around not being able to increase the financial incentives right now, given that there's been recent salary enhancement. But we can think about the possibility for the non-financial. I think Dr. Sarah touched it a little bit. It sometimes is in the interest of a health worker or a service provider to take action without actually being paid for their actions. If their actions will bring about some reward for their performance. So things around recognition, reputation, satisfaction. There's some evidence which even suggests that things like autonomy even have the outweigh the reward that one gets from a financial reward, actually. So some of those non-financial incentives, we need to critically think about them and think about how they can maximize the good and then minimize the potential for bad and the poor consequences that can be attached to incentives. I think as I conclude, we've learned from our discussants and the framing presentation that the RBF in Uganda has been made up of core technical components, and each of them has been designed strategically to maximize positive incentives while minimizing the unintended consequences, but that there's still room for improvement. And in Uganda, we've seen, or at least heard from Professor Sengova, that they still need to get some additional financial investments into institutional and capacity and technical capacity for RBF. We've seen that we need to document. We've had good process that's been discussed. We need to document that for purposes of sharing and exchanging knowledge. But also we need to conduct research around operational research, around audit verifications, around accountability, performance, around political economy. I think as I conclude, let's just really keep in the back of our minds that this is happening in an incremental way. We need to appreciate that it's going to happen step by step. And as we go along, we need to keep our finger on the pulse and know, is this still results-based financing? If not, what do we need to change to bring ourselves back to the original idea and plan that this was set out to achieve? Thank you, and back to you, Angela.
Thank you so much, Christabel. You have affirmed the pinnacle points that we've seen RBF attribute to us. You've left us 3 things for us for RBF mainstreaming to operate optimally: information system structures as well as processes. As we wrap up, we're really grateful to all of you. We are going to share all these materials with you. We are going to develop what we are going to call a compendium for all your questions with answers well articulated from the panelists. We will also share the presentations as well as studies around RBF. As we come to a close, Dr. Sarah, I want you to share some parting thoughts with us as nations consider how best to use available resources. I know Christabel has alluded to resource optimal use. How can other countries draw lessons from Uganda's experience with institutionalizing RBF? What aspects of Uganda's approach could serve as a model for other countries? In 2 minutes, Dr. Sarah.
Wow, thank you very much, Angela, and all the panelists and discussants. So as I wrap up, Uganda's RBF has been a little bit different in terms of its intended purpose, the design, implementation, and of course, the fact that we have achieved nationwide scale-up and later institutionalization. We were in project mode for many years, and I know many countries have not progressed beyond project modes, yet they aspire to institutionalize. So from our experience, one of the key things that we want to really reflect on and encourage other countries is to work within existing health systems approaches or functions. For example, we see that it was a stepping stone towards routine facility assessment and scoring. We know quality of care is very key. Many of us are talking about quality of care and thinking about which systems can we use to institutionalize our quality of care. So with the adoption of the health facility quality assessment as a routine and incentivization mechanism for quality, that would be a right direction of building the systems, but also using that as a way of incentivizing, because we have seen our quality scores improving significantly over the last 3 years, though we know that at a certain time it plateaus off because of certain other systems constraints. But overall, I think we will see increased client trust, confidence, and satisfaction in quality of services based on the utilization rates. In the area of strategic purchasing, we know that RBF has a potential to make systems more strategic in purchasing health services and aligning funding with performance outcomes. This has not been researched. I know my colleague, Professor Sengoba, may ask questions, but for example, our recent UDHS results or demographic health survey results show that health facility deliveries have increased from 75% in 2016 to 86% in 2022. That is in a span of 5 years. And also significant reduction in maternal mortality ratio from about 326 to 186 per 100,000. Personally, I know that RBF has a strong component in this because these health facilities deliveries, most of them are at our primary care facilities. And by increasing deliveries, it has impact on reduction of maternal mortality ratio. So RBF has been or has really impact, but that is yet to be done scientifically, as my colleague, Professor Sengoba, would like to say. So there's a lot that I can say, but I was given only 2 minutes to wind up. But I would like to conclude by making a few recommendations for implementation, that government support is key, because we know that government financing is the most reliable and efficient way for financing any health system. So by government adapting RBF approach as a way of financing its primary healthcare services, that is really a way to go and will ensure sustainability of such a strategic financing mechanism. We are implementing both the input-based and also the results-based. So the input-based is to ensure that facilities have the minimum amount to deliver services without compromising quality. And then those that perform more, they earn more based on the RBF mechanism. And I would also like to emphasize that we need to continue building capacity for purchasing and implementing RBF. We are not a perfect system. As Eric elucidated, we have many challenges, especially regarding the quality of data, the issue of ownership, embracing RBF and institutionalizing it at personal level. So really,
Looks like Dr. Sarah has chosen the right time to drop off. Thank you, all of you, for joining us today. It's been a very long journey for us learning. We hope to unlearn some of the things that we know, but also to continuously iterate. Thank you for joining us and hope to see you in the near future. Bye.
bye-bye. Thank you.
Bye-bye.
Thank you very
Bye.
much. Bye.
All right, thank you.